Good morning, everybody. Sam, are you there?
I am here.
Good morning. I just wanted to make sure everyone could see. Can you see the screen okay?
I can see the screen okay. I am still having difficulty, Chelsea, with it going in and out. So if you can control my screen for me for my presentation, I appreciate that.
You got it.
Thank you. Just going to wait for a few more minutes to make sure we're starting on time and some other people join in. Good morning, everyone. Just waiting a few minutes to make sure that everyone gets onto attending. Chelsea, I'm going to wait just 2 more minutes and then we'll begin, okay?
Sounds good.
Thank you. We just got so many people logging in all of a sudden.
I love it.
I love it too. Chelsea, can you see Brittany on?
Yes.
Here.
Okay, good. Hello, good morning to you.
Good morning.
I see Ruben and Martine as well.
Okay, great. I'm going to wait one more minute and then we're going to begin this presentation, our first presentation. So good morning, everyone. We're just waiting for one more minute for everyone to attend. How are you this morning, Miss Chelsea?
I am fabulous. How are you, Sam?
I'm good. I am excited. My voice is actually almost completely back.
I was saying, you sound great, loud and clear.
Thank you. Good morning, everyone. Welcome to the Greater Columbia Learning Curriculum. We're going to have a full day today. We will take some breaks, so we won't keep you for the whole 2.5 hours just in front of your computers. We're going to start out with the shared care plans and how to incorporate the patient's voice. I'm going to introduce Brittany Fox-Stading, which is our new patient navigator. Also with our shared decision aids on social determinants of health, Martine Sanchez, which you're very familiar with, as well as Ruben Peralta, and then a Now PAL demonstration. Okay, Chelsea, we'll go ahead and start with our presentation. So today we're going to talk about the shared care plan and the patient's voice. My name is Samantha Wardell, and I am the director for the practice navigators. I will go ahead and introduce Brittany. Brittany, can you talk about yourself, just give a little bit of background and where you came from and how long you've been with the organization?
Yeah, so my name is Brittany. I have been with Greater Columbia now for a little over 2 months. I recently came from Lourdes as a practice manager working on the other end of the practice transformation project. I have over 15 years of healthcare experience. I'm very excited to be a part of the team, and this is going to be my first learning collaborative that I get to present at, so very excited about that as well.
Thank you, Brittany. Okay. And just a reminder for attendees to make sure they put their name, the organization, and their title, if possible, into the chat box so that we can make sure that everyone gets credit for this learning curriculum. Okay, I'm going to talk about developing a shared care plan. So a care share plan is giving the patients the opportunity to help develop and negotiate their care plans. It transforms the relationship between the patients and the providers. By emphasizing transparency and cooperation in developing shared care plans, the practice can reshape and improve its relationship with patients. When patients are engaged in the process, providers can better understand patients' preferences, their values in relation to their health and their health care. In addition, patient engagement through a shared care plan promotes shared decision-making between patients and providers. In integrating care plans and settings, it is vital that all members of the care team have access to the same information and can build upon the same shared care plan. Team members must act in coordination toward a common goal to provide quality, integrated care, and avoid errors. In this presentation, we're also going to talk about how these milestones in your toolkit also relate to your specific milestone measures and how to meet those. So the elements of a shared care plan. The development and the use of a patient-centered care plan requires the ongoing participation of multiple members of the care team. Every professional who is a part of the patient's care should be familiar with the patient's care plan. This familiarity should become an expectation within the practice or its health system's culture. A shared care plan can be used as a tool for easy exchange of clinical information, medication reconciliation, and other forms of coordination between primary care providers, behavioral health providers, and other members of the care team. It is critical that all care team members refer to the care plan when managing and treating patients, and that they indicate any changes in the treatment or the patient status. As you can see in this particular slide, the team roles and goals is milestone 2A3, team-based care, milestone 2A1, empanelment status, and then if you look at the bottom, the patient education about conditions is also part of the self-management support. So I want to make sure that you're understanding when you're going through these shared care plans that it's also achieving a lot of your milestone statuses, and you can put that in your documentation when you're doing your reporting in the CSI portal. And then this is an additional elements of a shared care plan continued. So your medical and treatments, including pharmacological treatment, which is your medication management, and then role of the psychotherapy, community groups, other behavioral health or substance abuse therapy, and that's also part of your shared decision making. Counseling or coaching, and then plans tailored to the patient, the family context, the patient demographics, a list of the family members, any and all elements that would be included that you can get from the patient would be a part of that shared care plan. And to make sure that we're always engaging our patient and our family in any additional information that they want to tell you. Here's additional elements continued, the patient's preferences, what he or she might like to be called by the members of the integrated care team. As many of you know, I like to go by Sam as opposed to Samantha. The names and the roles of community-based support or services outside the healthcare system, which is the care across the medical neighborhood, milestone 6A1. A sign-out summary consisting of the integrated care team's brief overview of the patient's health status, which is team-based care, the patient's short-term and long-term health goals, and the action plan for achieving those. So 2A3, patient and family engagement. And there's other milestones that can be achieved. It's just how you want to be innovative in really implementing your care plan and how you want to set that process up. And continued on, more of the milestones, the patient's wishes regarding life-saving treatments. Milestone 2A3, patient and family engagement. A record of shared decision-making processes that have taken place. Documentation of conflict resolution strategies between the patient and the integrated care team, really having that interaction with the patient to understand if there's a conflict or they don't understand exactly what the treatment plan is, making sure that you're having those conversations with the patient. Any further information that patient wants his or her care team, just to reiterate that. These are useful resources for creating shared care plans and navigating. I have looked at each and every one of them. There's stories defined by them, and there's examples of the shared care plans. And I think it's very valuable information for you to be able to go in and see how others have created. Plus, we'll have a discussion about that today within our own group. And I'm going to hand it over to Brittany at this point in time.
Thank you, Sam.
You're welcome.
All right. One of the tools that you guys have to help with your shared care plans is utilizing your EHR. This is something we really wanted to kind of focus on, as I sent out an email last week, and a lot of the responses that I got, it appeared that not very many people were utilizing their EHR. It is very helpful to have the patient's shared care plan linked with the electronic health record system whenever feasible. Many elements of the care plan can then be populated automatically with the information that's already embedded within your EHR. When possible, staff with care and case management expertise, that would be those who are trained to assist and support patients in overcoming barriers to physical or behavioral health, can help lead the coordination process and ensure that the care plan reflects the input of the patient and other team members. So these can be the providers, your other case managers, a caseworker, behavioral health people, everybody who's involved in that patient's care team. One strategy is to have the patient fill out a form on a practice's online portal and have this information automatically populated as part of the care plan. That way you are guaranteeing that the patient is providing the input in their care plan. Additional information for the care plan can be provided by staff who carry out care or case management functions. We did provide an example on this slide deck. The link there will send you to a good example that was done by Cherokee Health Systems in Tennessee. And then Sam, I don't have access to actually click on that. They will have access to these slide decks, correct?
Yes, they will. It will be posted on our site, as well as we can send them out as in addition to Chelsea sent them out as well.
Yes.
Okay, great. All right. Next slide.
It looks like we do have a couple questions. Did we want to address those now, or?
Yeah, we can go
Let's wait until the very end when the questions, and we'll put them all with all of the other questions that came in for Brittany at the very end. Is that okay?
Yep. I just want to double check. Thank you.
Thank you.
Okay, next slide, Chelsea. All right, engaging patients in creation of their care plan requires the participation of multiple members of the team. One or more members of the team should become skilled at introducing the process and developing health goals and creating the action plan. Getting the patient's permission to exchange information should also become standard practice in the setting. Developing the care plan is commonly requires multiple visits. And also just wanted to put this out there as well. The care plan is something, it's a living document. It's not something that it's a one and done. It should constantly be evolving as the care of the patient evolves. Discussing under the care plan should address links between both physical and behavioral health. When patients are engaged in their care plan, they have control over communications that may go beyond the care team. For example, patients can indicate who they want to be notified of their care plan. This includes community networks or family members. So the whole point is to have the patient be involved and be the center of that care plan. Providers should be prepared to talk with the patients about the information sharing and confidentiality of the care plan. Once the care plan is in place, it provides a mechanism for review that is broader than a medication list. Reviewing the care plan annually at a minimum is best practice, and it can be done face-to-face or through the patient portal. As you become more comfortable with the patients and you have been working with them, some of this stuff can be done through an online venue, like through a patient portal. They don't all have to be face-to-face. All right, next slide, please. And then we provided some more useful resources for you guys that you can do. Again, these are links that you can go ahead and click on. These slides will be available for you on our website after this, so you can go ahead and have some more resources there. We will go ahead and go into questions. Like I said, I had a couple of questions that already came up. Sam, please feel free to jump in and help with this if you have anything to add.
Definitely.
So one of the big questions that we have is how other entities are making this a more formal process. A lot of the comments that I got, it seems like this process is being very manual and hard to track and not really utilizing the EHR very much. So that's one of the issues that I see that came through with a lot of the questions. And I know, Sam, you had some great information on that. Would you mind taking that one?
No, I don't mind at all. So this is an open discussion, so if we can unmute people so that we can actually hear the comments come through. One of the, I can give an example of what we did for Oklahoma State University. We were part of the CPC and CP Plus program, as well as we were PCMH certified. We also sat on the board for CMS services. And so our shared care plan, we had NextGen at that point in time, and it was very difficult to build those templates, and in addition to put the social determinants of health integrated into this particular shared care plan. What we did is we used our discharge summary. And so at the time the patient was within our 32 resident program, at the time the patient was discharged, they put all the elements of a shared care plan so the patient understood what medications they were prescribed that day, to make sure what they discussed with the patient, what their responsibilities for self-management was, just the elements that within your organization that were pertinent to make sure that your patient left with something that was very valuable to them, and that was and they were able to understand it. So that's one of the areas, or one of the implementations that we did. We used our discharge summary, and then going back and using our residents to do more documentation, as well as our oversight attending, and then our care management staff, making sure that they included all the elements that that particular organization wanted to implement into that summary, to use it as a care or a shared care plan as well. And can I ask for other people that have shared care plans within their organizations, how they are implementing those?
Hey Sam, hey Sam, this is Martina. I can give out a few examples of how some of the sites that I'm working with are doing shared care plans. Would that be okay?
Perfect.
Yeah.
Thank you, Martina.
So, yeah, you're welcome. The first, organization that comes to mind, and they've been doing a really great job, and this is actually a behavioral health and substance use provider site that we work with. This is Merit Resources in Ellensburg. And I bring them up specifically because, since they're not necessarily primary care, there's some other, kind of hoops that they have to jump through in order to get shared plans established with their patients' primary care providers. And that's if they have a primary care provider. But for them, they are required to get a release of information from those patients because, it is protected information, more if it's, on the substance use disorder side and on the behavioral health side as well. But, Merit, they are working on, establishing those releases of information for those patients that, have identified as having a primary care provider, and they do education as far as to, the benefits of having a shared care plan, not only for the providers, but also to the patients. And right now, with the situations that we're going through with COVID, the healthcare authority does have a waiver for those releases of information, since, in the counties that we work with, we're in different phases. In some counties, people are, able to go back into the offices and see patients, others are not. So for those that are not able to come in, they get a verbal release of information, make sure they document that. And then once the patient is able to come in, then they, get that wet signature. But, they are doing electronically, sharing those shared care plans, those care plans electronically with those primary care providers for those patients. Others are, just working on that, where it is a more manual process, because, they're just getting started with this piece, and that's more for the year one cohorts that we're working with. Even, year two, they're working on this, and they're making great progress. But yeah, it is, the sites are doing it differently, and it depends on the organization and what services you are providing. But this can look many different ways where, you can use your EHR, and that's where the interoperability comes into play, where, it makes that sharing of information a lot easier, and it makes the sharing, seamless. And it's a lot faster than you doing it manual process.
Right, and you're also there as the practice navigator to be able to assist with that, aren't you, Martine and Brittany?
Yep, that's our job, and that's something that I really enjoy about this job is seeing things like this being implemented, and hearing the great outcomes that they're having. Who is it? Quality Behavioral Health. They're also doing shared care plans where they're the case manager, sits in with, the patient and the provider if they want her to, so that she could be, more involved. And, again, they're doing it electronically, sharing those care plans, but they are, putting a lot of emphasis on this because they are seeing, the great outcomes, and just how the patients have perceived the shared care plans, more for those that were hesitant at first. But now, they're really enjoying the benefit of having that, and also having, that support of the care manager for them.
Yes, in addition, they're one of our exemplar clinics, so that means that they are providing additional education to our other cohorts as well. So make sure that we get that out there, that everyone takes advantage of that. I see Shireen from Merit is on. Shireen, do you want to add anything to that story that Martine said about your great clinic? Shireen? Oh, sorry, Martine.
It's okay. No, but they are doing a really good job with the shared care plans.
Can you hear me now?
Yes, I can hear you now.
Hi, this is Shireen. Thank you. I had some technical difficulties there getting my phone unmuted. Yeah, it's been an interesting journey. We have worked really hard at our integrated practice transformation. We've done some great collaborative work with Kittitas Healthcare, with Community Health of Central Washington. We have signed memos of understanding with both of those organizations, and we have been able to achieve some great relationship building. So we have a warm handoff. We have a release of confidentiality, of course, signed on our end, and then we're able to connect our participants to a primary care physician if they don't have one. We're also, of course, getting the information from Collective Medical, so we're able to do within 7 days follow up with those individuals that have an emergency department visit. A lot of our participants, they really aren't aware of how to use their primary care physician. They have a history of being in crisis and going to the emergency department, and that's where they've gotten their care. So I think it's been great as, our goals have been to connect them with a primary care physician, to establish a relationship with them so they're not utilizing the emergency department. And that shared care planning is all, helping us to achieve those goals. So I appreciate the opportunity to share that, and we have seen some great success with the integrated managed care.
Thank you. Can we talk about the EHR challenges? Martine, can you talk about that, what you're seeing out in the field with our providers?
Yeah. So, and you guys mentioned it earlier too, is those templates, they have to be built into the electronic health system. If not, that creates some problems, and then also making sure that, in the background of the EHR, that everything's mapped out correctly, because if something's not really set up the way it's supposed to be, and in the back of the, in the background of the EHR, when they're inputting information, maybe at the front desk or the medical assistant or the provider, then there can be some data that, might not autofill into those spaces if, you guys have that function, or, just not having a template, which, really creates really not, the best scenario for having a shared care plan. Those are some of the things that we're seeing out in the field. And then, just again, just knowing, what patients have a primary care provider, if they're willing to share that information. But there's a lot of other issues, but those are kind of like the main issues, making sure that it's really set up, within your EHR, if we have those templates, and that it's really mapped so that the information carries over to those templates. And it doesn't, create any confusion as to, hey, why is this data here, or where did it go? Because we have seen that as well. And then having multiple EHRs for the organization, that can also create some issues. There are some organizations that have multiple EHRs that they might not be able to talk with each other if there's no feed between the two EHRs, so that can cause a problem as well. So just really making sure that utilizing your EHR to its full functionality will create some great benefits when doing shared care plans.
Martine, can you give an example of entities that are actually doing it manually and how they can streamline that process if there's not any resources available for their EHR to really be able to implement that? Even though that you're able to assist them with that, you might have some examples that they can start getting started on.
Yeah. We are working with Chaplaincy Behavioral Health, and they're a great example for this. They're in their year one, at the end of now in quarter three, since we're in quarter three of practice transformation for them. At the beginning, they didn't have an electronic health record. They were just using paper and Excel sheets and other documents for this. So that really, it was just something, they were trying to do shared care plans, but you can only imagine the challenge that, comes along with that, having no electronic health record. Going into this, in the first quarter, as you all know, it's kind of like the planning stages, what do we have in place? What do we need to implement? And, what is it going to take to get us to that implementation phase? We worked through all those issues. We, came with their quality improvement team. We came during one of our meetings. We brainstormed different ideas as to, because they were looking for EHRs, and they were just looking into, what functions do we want our EHR to have. And that was really great to see, because, you got to see kind of like the clinicians, we want our notes section to be, so it won't have a lot of issues, that it's easy on us. So they worked through those issues, and now that they have implemented, their electronic health record, they're going more back, they're leaning more on their EHR rather than doing it on, that manual process, which is, really daunting, and there's more chances of, errors occurring if you're doing it manually than if it was automated in the electronic health record.
This
is Carol. I'm sorry. This is Carol.
Good morning, Carol.
Good morning. Nice to hear your voice.
You too.
So, do all electronic health records have a format for shared care plans? I know they're probably a little bit different, but can they all be used? Do all EHRs have that capacity?
They do not. There's template building that might need to be, and we can actually, I want to hear from the group on this particular one. I know that there's modules that can be purchased for some of the larger ones. Like I said, in NextGen we really utilize, but they've come a long way since 6 years ago at Oklahoma State University, but using the discharge summary was just one of our ways of being able to implement that. I've seen other methods, and I've seen templates, I've seen modules, but if we could hear from the group, that would be great. Or Martine, if you want to speak on their behalf, that would be great as well, or call someone out that would be able to speak on that.
Hi, this is Myrna Ridenauer with Lord's Medical Center.
Hi, Myrna.
Hi. One of the difficulties that we have with the EHR is to do the shared care plan. We actually had to build it into our EHR, and it then had to go through, in regards like where it is, it takes the provider 7 steps to get into it, to fill it out. after we had built it. And that's just based upon what our EHR allows us to do at the moment. So first we had to choose something that was going to be simple for the providers to use. And we've chosen to kind of start with our diabetes and depression patients, since those are the ones that we kind of want to get more engaged in their care. And we're struggling with still getting our providers to use it. And I think one of the barriers is the fact that it's not something that can easily be queued up or pulled into the visit. So it's not part of, say, the encounter, and so they can go through and find it and say, oh, hey, of these 4 things that you want to focus on, diet, exercise, weight management, or other, which one is the most important to you? And it's been a struggle for us to get people to use it. And I think primarily it's because it is so hard to have something built in and not already ready for us to pre-populate.
Thank you. Anyone else would like to share, please?
Hi, Sam. This is Catherine McDaniel from Yakima at Community Health of Central Washington. Our system is not dissimilar to the earlier speaker. I'm so sorry, I forgot your name. But we have one that is built into our EHR, though it required hiring a consultant to help us figure out how to make the templates. It wasn't an easy process, but we built 12 different individual care plans, and then they're all modifiable for specific patients. I don't think it takes 7 clicks for people to get to them, but again, they're probably not as easy to find as we would hope. But our care coordinators are happy with them, and the patients are engaged in putting them together. So I would call it a partial success.
Thank you. Anyone else, please?
So Sam, this is Carol again.
Muted.
People are thinking about participating in this conversation. I really appreciate it because there's a lot of conversation at the state level about having one format for a shared care plan, and I can see that that could pose some difficulties for our providers, and wondering if there's any advice you could give us that are working on these kinds of policies in order to make it easy for providers to have shared care planning, and whether or not there needs to be one standardized format for everyone.
Carol, this is Kevin Taylor. And for instance, in our setting where our clinics have Athena, EMR, and our hospital has Meditech, it's difficult enough for them to talk back and forth. And if we tried to overlay a one solid single format on both those EMRs, it could be pretty tough. In other words, usually when we try and share things, we have to sort of mold it and shape it, based on our own tailoring, if you will, so that Meditech can take it and Athena can take it. And so I think we would find it difficult if a standard format was imposed on top of that.
Thank you, Dr. Taylor.
Yes, I can definitely, Carol, I can definitely speak on their behalf for that, for an advocacy that, with the different EMR systems, that's going to be a very difficult situation for a formalized approach to a shared care plan. Okay, can we go ahead? Thank you. Can we share some stories about how we're doing our shared care plans and how, with the challenges of COVID? I know that we have a lot of telework right now, so if we can share some of those stories, I'd appreciate it.
So for this, Sam, I would like to have Whitney Bone from Quality Behavioral Health, see if she could share what they're doing, because they're, I like what they're doing as well. They're doing an awesome job with the shared care plans as well. So Whitney, do you mind sharing what you guys are doing as far, as far as shared care plans? Oh, she doesn't have audio. Okay. But they're using, I can talk a little bit about this. There for them, Whitney is their practice care manager there for those patients, that are, she's focusing on those high risk patients, from their risk stratification. And to do this, they, utilize different tools. They have this tool called the Sunshine Model, which is basically a sun with sun rays poking out of the sun, and then those are the social determinants of health that they identified. Then based off those social determinants of health, what the care that's been given to the patient, all that goes into the care plan. And then Whitney, shares it with the primary care providers if they have that release of information. And like I was saying, she can sit in with those patients if they feel that, maybe they don't feel too comfortable with, being by themselves with the provider. She can go in. Now in the times of COVID, she is able to join the call. So I don't know if it's easier for her than to be, in person, but she's able to join in the call with the providers. They do have a psychiatrist that just started providing telepsych to patients there in Clarkston. And yesterday I had a call with Whitney where she said that, I believe it was this week or last week, that they had their first appointment there with that psychiatrist. And it was a little boy, a kiddo, that she was able to sit in and participate in the call as well. So they're doing it different ways as well. They're able to share electronically, or they're able to sit in with those patients in their appointments, or they're able to kind of fax those over. So they're doing it different ways. Just to work around, the COVID and, also all the technical challenges that come along with, trying to send electronic health information to other providers.
Thank you, Martine. Anyone else have an example that they'd like to share, please? I'm going to pick on Chris a minute. Chris from Catholic Charities.
There we go. Hey, Sam.
Hi. Chris, can you
I'll tell you what.
Challenges with that during the COVID and trying to communicate with all the other community services as well as your
Yes.
PCPs?
Yeah. I think that this has been such a trying time that one of the challenges we're seeing is that unless we're setting regular meetings with our community partners, then we're going back to those kind of siloed services we had in the past. And I don't think it's intentional. I think that one of the challenges we have is that without those opportunities for the face-to-face meetings, our meetings with like Sundown M, and other community partners, Virginia Mason, are all being set aside. So we've had to make intentional decisions about reaching out to people and setting up times to have Zoom calls so that we can continue to collaborate with them. One of our closest partners, like Somerset Counseling, if I don't text Jamie on a regular basis and just check and see how she's doing, we're it just feels challenging. So as we try to like coordinate collaborative services, trying to just maintain those contacts and those relationships with our community partners is a challenge. So.
And how are you documenting that within the patients while during this time?
So like our shared programs, so like what we're doing with Somerset is that we have the client active in both services. So we're able to like document in our electronic health record that we're providing an assessment and that they're seeing Somerset counseling for SUD services. And that seems to be going okay. It's challenging in that level of collaboration isn't as high as it was 6 months ago. So making sure that we're touching base and coordinating is so important right now.
Thank you. We have a few more questions in the chat box as well. I can't see those. I can't see them completely. Chelsea, can you see those?
I can see them. I'm scrolling up here, so I'm just going to go to the very tip top, and we'll see. I'm sure some of these have already been answered, but just to make sure we cover all of our bases. What system are you using for the shared care plan?
Okay. If everyone would like to share, Chris, what program are you using for your shared care plan?
So we built it into our treatment plan with our EHR. So we have CareLogic from Qualifax.
Thank you. And Shireen? I'm just picking on the ones that I already spoke, but if anyone else would like to speak out.
Sure. We have not implemented this as part of our electronic health record yet. We're in the process of investigating what's the best way to do that. Having that information on the discharge summary is the best we've done so far, but we're working on it.
Okay, thank you. And I think your best resource is your practice navigator and being able to connect you with other like EMR systems or HR systems so that you can collaborate on what the most efficient process is. Anyone else would like to say anything on this particular question? What's the next question?
All right, then I have one on who should coordinate the social needs for the patient. We hear that this is the role of the MCOs, the primary care team, and a community-based care coordinator.
Okay. So we actually encourage that the primary care be the and the team within the organization. As we went through this slide, we talked about team-based care, and it takes the entire team from the front office and to the medical, all the way to the medical records and the billing office to be able to really make sure that they're collecting that information, you're utilizing that information that's available to your physician in order for them to be able to provide those care management services. But if everyone else can speak on how they're doing it within the behavioral health organizations, the SUD organizations. Martine, you want to pick on someone?
Yeah, let's see. Tom, do you want to talk about what you guys are doing? So Tom's from Triumph Treatment Services, which, for them, they have a site, it's called Wheelhouse, that they're going to practice transformation. I'm not sure if he has audio, but if you can talk to this, Tom, please feel free.
Yeah, I hate to throw Teresa under the bus, but I think she's on the phone, and she could probably describe what's happening at Wheelhouse better than I can.
Can you tell me the question again?
Yes.
Chelsea.
Yes, who should coordinate the social needs for the patient? So we hear this with the role of the MCOs, the primary care team, and a community-based care coordinator. So who should coordinate the social needs for the patient?
Okay, so our PTI site is in our long-term care facility. We do the primary coordination of services for the patient. You know, I really think it just depends on the situation. I think we have some MCOs that are particularly upfront and very helpful about wanting to do care coordination and wanting to participate with us, and some that aren't. And I think it depends on the type of care as well. You know, if it's medical, our medical assistant might be the one who's better equipped to help coordinate that particular point of contact or that care. If it has to do, you know, with the substance use disorder, having the primary counselor be the one that is upfront on that. If it's mental health, having the mental health therapist work and walk through that, or the psych ARNP. I mean, it really, I think the Real House team has done an amazing job on working together as a team, identify the need, and put the person most able to meet that need at the front steps of the care coordination.
Thank you. And we only have just one more minute left. Chelsea, can you look at the questions that haven't been answered?
Well, we just got one, and I'm not sure if it's been answered from, let me see, scroll to the bottom. What would it take for every healthcare organization to use the same EMR? I feel like that's a good question.
A miracle?
Surely you jest.
For the very last minute.
Does anyone want to answer that? But from my point of view, just being around the medical field for over 20 years, each organization is very defined differently, and their needs are very different, as well as their different processes, and not to mention that very, very expensive EMR systems and what their resources will allow them to have. So I think that, you know, it really would have to be more of either a statewide or a national type implementation, and the resources would have to be available for the implementation to be the same. So that would be my answer. Anyone else want to speak out to that?
This is Kevin Taylor, and I think what we're going to have to go down the line of increased interoperability so that different EMRs can talk to each other much better and exchange data much better. The hope of getting everyone on the same EMR is, I think, a virtual impossibility. It would cost billions of dollars nationwide to do that, and it would be almost impossible for people to give up all the proprietary stuff they have. But certainly, causing different EMRs to be able to talk to each other better, interoperability, whether it's mandated or whatever, I think would really be the direction we really need to pursue aggressively.
Definitely. Thank you, Dr. Taylor. And definitely that interface operability to be able to pull certain criteria that the state is requesting and set up on a certain platform is definitely the way to go. When Carol was asking that question for a shared care plan that is consistent across the board, that would be one way that would probably be the only way we'd be able to achieve that, is if they had certain criteria and then it was set for the EMR to be able to pull that data into a certain platform.
Great.
Okay, well, thank you. We'll take a short break right now, 10 minutes, and we'll meet back and resume our next presentation with Martine and Ruben. Welcome back, everyone, and we will get started on our next presentation, the social determinants of health screening. This time I'll give it over to Martine Sanchez and Ruben Peralta. Chelsea, are they having problems with the mute button?
Let's say I just unmuted Ruben. Martine, Ruben, are you there?
Yes, I am. So I started really well for like 30 seconds. So you weren't able to hear me then?
We can hear you now, Martine. I just unmuted you as well. Sorry, guys.
Okay, let's hope I have as good of a start as I thought I had first. So what social determinants of health? Many of you, I'm sure, have heard about them, and they are a very important part of the healthcare conversation in the last few years. So what I'm going to share in the first slides, it's probably not going to be news to anyone present, but you know, hopefully it'll serve as a refresher for some of you, and it will probably help set the table for Martine's part of the presentation, which he's going to share some of the more practical slides and what we can do. So yeah, let's go to the next slide, Chelsea. So what research does point to the association between unaddressed social determinants and poor health outcomes. These factors have a significant impact on individual health and collective health of our communities. So GCACH considers these determinants as part of our overall health care delivery system. Next slide, please. So some of I just threw in some here. There are many, as you can see there. You know, there's too many to count. But later on, we're going to talk a little bit about the adverse childhood experiences and resilience, which these happen to also be social determinants of health, but they were isolated in 3 categories, and 10 of them were studied that Dr. Vincent Felitti and Robert conducted for several decades. And so we're going to talk a little bit about them too, because these social determinants are probably the ones that have the most data out there, the ones that have been studied the most. So we'll touch on them. So let's go to the next one. So here it is. 80% of our health is determined by these factors that I just mentioned. It's in the physical environment, health, behavior, socioeconomic. So those are the social determinants, the social factors. And about 20% of our health is determined by the health care we get from health systems. So that's why we consider that it's very, very important to start addressing those upstream issues to prevent it, in some cases, reverse some of the conditions. Next, please. So the ACEs study that I just mentioned, it was a decades-long study by the 2 doctors that I just mentioned that involved over 17,000 people. Well, there they are again, Vincent Felitti and Robert Anda. They looked into the effects of adverse childhood experiences over the lifespan. And it's the largest study ever done on this subject. So they had 10 questions for their study subjects, patients, broken up in 3 categories: physical abuse, neglect, and family dysfunction. So the higher your score on those 10 questions, the more likely you are to suffer later on as an adult and throughout your lifespan of several mental health and physical health conditions. Next slide, please. So here's a list of what the study showed, that you are more likely to suffer of several times more than someone who did not have any adverse childhood experiences. So again, the list is long, and so yeah, let's move on to the next one, please. So again, you know, the main factor of this abuse is what it does to the brain development of a child, and this is the most significant determinant of nearly every negative health outcome, behaviorally, mentally, socially, emotionally, and physically. So the abuse and those social determinants affect the brain in many ways. But however, influences like caring adults in positive environments influence healthy brain development, and they can even be reversed in adults, and that's what we're hoping to do. Next slide, please. So here are some protective factors. Whoa. Okay. So this is what the rest of us as a society can do to help prevent ACEs, to help prevent the social factors, and also to help reverse some of the impacts people are suffering as adults. So these protective factors are being promoted by many organizations who have taken on this task. So parental resilience, for example, if we as a society can help parents build that resilience that can help them recover from difficult life experiences, that would be excellent, and that's kind of what we're talking about here today. Social connections, relationships, which provide emotional and informational, instrumental, and spiritual support. The knowledge of parenting and child development, having programs that parenting classes to help parents with support, with physical, cognitive, and language and social and emotional development. Concrete supports in times of need, and this is probably where professionals around children and families can help more, provide that type of assistance like housing, food, and healthcare. Those are the areas that can help tremendously. Also, because overall, you know, they often mention phrase of, you know, children don't come with a manual, and most of us parent the way we were parented, and many times that we get into that unfortunate cycle of generational situations where you just keep doing the same thing over and over, what you learn from your parents, and many times it's not, those practices are not the best parenting practices. So the last one there, social and emotional competence of children, family and child interactions that help children develop the ability to communicate clearly, recognize and regulate their emotions, and establish and maintain relationships. So these protective factors, this is what we can help as a society, and those of us who have survived any type of social determinants, whether they land in these categories of the ACEs or poverty or racism or any other social determinants, those of us who have excelled in spite of it, and who work in professions that can do something about it, we definitely should do it. Next slide, please, Chelsea. So the next few slides are going to be a little bit of what Greater Columbia has done in regards of social determinants and ACEs. As many of you know, we conducted a pilot on a community resilience campaign. This is a media campaign in English and Spanish in many platforms that also has a component, an in-person training component, which we got to conduct 2 trainings before COVID-19 hit. But this is a campaign that, like I said, is mostly media, and those in-person trainings are to bring in professionals that work with children and families to to train them on the near science and how adversity affects child brain development and those protective factors those are included in the training as well. So we put together a group of subject matter experts to advise us on what the messaging should be, what the focus should be, and that's how we came up with the training should be around the near science and the different media platforms and the in-person trainings. So that pilot was conducted from January through March in Yakima. It went really, really well, and we're in the process of considering expanding it to the 9 counties. So we had to put a pause on that plan because of COVID-19. The board recommended that we look at any more immediate benefits, basic benefits that might be needed out there, and so that's what we're working on right now. We just completed a survey. It should be going out any day now. We hope that all of you can complete that survey and forward it to any other organizations, because we're trying to figure out what direct benefits can communities benefit from, or they're being impacted by COVID. We want to be able to help mitigate the impacts of COVID directly, and we want to collect as much information as possible by county, so we can be very, very intentional and very targeted on our efforts in each area. So there's the address for if you want to visit the page. So this budget is for $600,000. We spent $100,000 in the pilot. The budget we put together for the 9 county launch is a little bit over $400,000. So we have a few. And we're already investing some of that leftover money on the masking campaign, for example, that I don't know if you've heard about it, but yes, we're working on a Spanish language masking campaign that we were asked to conduct by the Ben Franklin Health Department. So, okay, next slide. Okay, so here's also one way we started addressing with working on social determinants of health. As you know, we have local health improvement networks throughout our region, and we asked them to survey the Medicaid consumers in their areas to ask what social determinants may be the most challenging for them to reach and maintain good physical and mental health. So that process was conducted back in 2018, and the different local health improvement networks came up with the survey results, and the next slide shows them. Okay. So here we have on the left the local health improvement networks. We invested $1.4 million through 2019 through 2020. This money is already out there, making a wonderful impact in the different communities. You can see there which social determinants each LIN region chose, and you know, from the survey, and most of them looked at 3 to 4, and some of them narrowed it down to 1. So as you can see here, the different categories that they chose to invest the money we made available for their particular region. So I'm going to show you on the next slide just one example of the local LIN here in Ben Franklin. So this is where the money they got. Here's where it went. I can certainly distribute where the other LINs, where the money went for the other LINs, but this is just as an example of the different social determinants of health that are being addressed, at least in these 2 counties. Next slide, please. Okay. We reacted also very, very quickly to the COVID-19 pandemic. We moved some money around so we can start affecting the pandemic, so we can start reacting to it right away. Our website, we keep provider and stakeholder communities for local, state, regional, and national resources. So we include information there. We invested $276,000 for 51 organizations to implement telehealth. We offer technical assistance for providers, training, billing, and new regulations. Leadership council meetings focus on impacts to the regional economy, social determinants, and recovery efforts. We donated $300,000 to Second Harvest, and this was back when the pandemic first started. It was around it started like a month before, but we made this money available on April 17th to Second Harvest, and then they distributed to about 45 other food banks in our 9-county region. And also we put together care packages for skilled nursing facilities and made hero awards from, it sounds like the residents of these nursing facilities are really enjoying these care packages. And maybe Becky or someone can elaborate on that a little bit. And also, we participated on statewide committees to advance telehealth and broadband, and Benjamin Franklin local decision leaders briefings. Next slide, please. And this is where Martin takes over with the more practical information. I don't know, Sam, do you want me to answer any questions now or wait until Martin is done?
Let's just wait until Martine's done and then we'll have overall questions, please.
Okay.
Thank you, Ruben.
All right. Guys, so this part that I'm going to be talking about has to do with, the next few slides have to do with social determinants of health and the different screening tools that are used out in the field. As you guys are aware, there are many tools that can be used to screen for those SDOHs. They can range from, being, evidence-based to, hey, these are the only 3 social determinants of health that we have capacity to, screen for, and also to provide resources, because it's not just the screening, that can happen, but also, now that you know what resources, that a specific patient needs, how do we get those resources? Do we have any, connections with those resources? Do we have information available? So these next slides will talk about, some screening tools that are being used out in the field, and then also, a success story that came out from 2 practice transformation organization sites that came out from screening for social determinants of health. But first I'm going to start with the Prepare tool slide. So if you go up 2 slides, yep. So this is the Prepare tool. This is a national. This tool was created by the National Association of Community Health Centers. And a lot of the federally qualified health centers use the Prepare tool to screen for the social determinants of health. I can tell you that Tri-Cities Community Health is using this. Yakima Neighborhood Health Services, Columbia County Health Systems is using this as well, even though they're not a federally qualified health center, but they're using it. And how this tool can be used. It can, for those sites that I mentioned, they have it integrated into their EHR, which is, better rather than, having a paper. But then again, that depends on your organization size and what resources, are available to implement this tool. On here, the next bullet point is what Prepare tool stands for. So that's an acronym, Prepare. So it stands for Protocol for Responding to and Assessing Patients' Assets, Risk, and Experiences. So that's what Prepare stands for. And they emphasize in capturing measures that are actionable that, will result in some type of action once, those questions have been answered and the providers identified what resources are needed. So something that's actionable. And the next bullet, it covers the core measures. What measures it covers. So there's race, ethnicity, migrant and/or seasonal farm work, veteran status, language, housing status, housing stability. It also asks for address, neighborhood, education, employment, insurance, income, material security, transportation, social integration, support, and stress. So those are the core components that it measures. And altogether, this tool is 21 questions that can be, again, depending on the setup of your site, can be administered via many ways. It can be administered via the clinical staff or the non-clinical staff, which would be your front desk staff. And that can be those front desk staff, the non-clinical staff asking the questions to those patients, and then them writing in their responses, or also having the patients fill out that those questions, whether that be in a tablet or any other form or any other way that can be administered. And on here, I also provided the link to where there's more information on the Prepare tool. They have a toolkit that they developed that goes into depth about the implementation process and resources that they have available as well. So you'll have this in your slide deck. Next slide, Chelsea. So this other tool, this is the social needs screening tool. And this tool is what's created by the American Academy of Family Physicians. And on there, we see the Everyone Project. So they developed this tool and in response to the Everyone Project. And the Everyone Project, this is, the vision of the American Academy of Family Physicians to transform healthcare to achieve optimal health for everyone. And to achieve this, the American Academy of Family Physicians is taking a leadership role in addressing the diversity and social determinants of health as they impact individuals, families, and communities. To help realize this vision, AAFP launched the Everyone Project to help family physicians take action and confront health disparities head-on. The Everyone Project focuses on providing family physicians and their practice teams with education and resources advocating for health equity, promoting workforce diversity, and collaborating with other disciplines and organizations to advance health equity. So that's a small description of what the Everyone Project is and how they tie in the social needs screening tool into that project. The focus of that project, again, is to provide family physicians and practice teams with education and resources. One of those resources that they have available on their webpage is the Neighborhood Navigator. So after they have screened for social determinants of health using their this tool from the AAFP, then they created this resource, the Neighborhood Navigator, because again they just didn't want to provide this tool without having any resources available for those providers or those organizations that are planning on using it. This Neighborhood Navigator, which I include the link to as well on this slide, it's pretty cool because it gives you it gives you resources for food, housing, transportation, employment aid, legal aid, and financial aid as well. And it's pretty easy to use. Once you go on their page, you just enter your zip code and hit search. And then it gives you, different resources for the things that you're looking for. And it gives you, once you type in your zip code, then it gives you, what type of assistance are you needing? Is it food, housing, transit, physical health, mental health, care, money, goods, family, work and education, and legal. And it has different drop-down menus on those different categories. that you can say, for example, say, hey, I want mental health. Do you want mental health care, individual counseling, substance abuse counseling, 12-step, or mental health evaluation? So it gives you different topics where you can select from. Same for housing. There's help finding housing, temporary shelter, help pay for housing, help pay for utilities, maintenance and repairs, help pay for internet or phone, and housing vouchers. So there's different resources that they give on there as well. And on here, you guys can see, based on those resources, that's what this tool are the core measures for, housing, food, transportation, utilities, childcare, employment, education, finances, personal safety, and assistance. And same as the Prepare tool, this can be, either self-administered or administered by clinical or non-clinical staff, again, depending on the setup of your organization. Being with Greater Columbia for 2 years now and working in different, settings, healthcare settings, hospitals, primary care, substance use, behavioral health, big and small. There's, different ways that organizations are set up and sites, individual sites, depending on the manpower that they have available. So, these are different options that that they provide as to how it can be implemented or how it can be administered, depending on the manpower that you have and the resources that you have. And then on here we have, again, I provided the link to the actual social needs screening tool, and compared to the Prepare tool, this social needs screening tool is only 15 questions. So a few, 6 less questions than the Prepare tool. The Prepare tool, if you guys remember, was 21 questions. And then for this social screening needs tool, the last question that's on there is, they ask you, would you like help with any of these needs that, hey, I do need housing, I do need help with utilities. Then that lets them know, hey, let's reach out to this person and try to figure out how we can best, provide those resources. Or, hey, we're aware that this patient, is needing some resources, but they, mentioned no, maybe in their next visit, then we can, talk to them about those needs that, were identified in their previous visits. So there's, different ways as to, how to use these screening tools. Next slide, Chelsea. So this, so we talked about the Prepare tool and the social needs screening tool. So those 2 tools are evidence-based tools, that were developed by big organizations. And then this is, in the beginning, I mentioned that there's, tools where, that are evidence-based, and other tools that are just being implemented that say, hey, this is the only things that we can screen for now. This is an example of Providence St. Mary, what they are using for their social determinants of health screening. So they, it's a small page, I want to say a quarter of a page or half a page with this, where they're, write in their name, date of birth, and phone number. And then on here, you guys can see that they just have little check boxes with pictures right next to them. And then, so all they would do is get this piece of paper, write in their information up on the top, name, date of birth, phone number, and then coming down here to the check boxes and just seeing, okay, well, I don't need housing or rent. I do need food assistance. I do need, help finding a job, and I need dental care. So they just go and select those items, and then they give that to the front desk or the medical assistant. Then they enter that into their system. So there's, like I said, there's different tools that can be used. So this is an example of a tool that was developed by Providence St. Mary, which is one of their practice transformation sites that, they have implemented. Next slide, Chelsea. So this example, this is who it's more of the process, and you guys have seen this in the two previous slides. Screening, SDOH screening process. So who can screen for SDOH? Medical assistant, care coordinators, outreach team, front desk, so your non-medical staff, and how do providers see this data? So this information that I'm talking about actually came from Yakima Neighborhood Health Services. So this is their process that they are using for the Prepare tool. So they're using the Prepare tool. So this is how they are using it and who uses that tool. So on here we see medical assistants, care coordinators, and the outreach team. And then so once they use that tool and they screen somebody, how do providers see this data? Because that's also important that providers see the social needs that they have, because that can give them a better picture as to why they're not being, for example, compliant with their diabetes medication. When they have no housing, they're not going to be worried about, hey, I need to take my medication. They're probably going to be more worried about, where am I going to sleep tonight, especially in the winter where it's cold, there's snow, ice. So there's we want the providers to see that information. So for Yakima Neighborhood Health Services, they have once they screen that population of a problem list. So they have a problem list that automatically populates based on the selection of the on the Prepare tool. On those that problem list, they actually attached Z codes to those social determinants of health. Those Z codes then print on providers' master documents where they're able to see, okay, this, they need housing, food, and transportation. And then on the next slide, if you can go on the next slide, Chelsea, you guys can see, I don't know if you guys can see it very good, but on here, this is a sample patient that, Rhonda, provided a screenshot for on how those questions from the Prepare tool populate that problem list. And this is on here, what you're seeing on the screen is what the provider sees. And then if you guys see on your far right hand, there's the recent notes on here. There's that column on there that says recent notes. On there, you guys see more to your right, more right there. You guys see added from Prepare template, added from Prepare template, added from Prepare template, added from Prepare template. And on there, you guys can see that, and then I'll go from top to bottom, lack of adequate food. So that, they selected that on the tool, so that automatically populated the problem list that the provider sees. And then also infrequent contact with primary support, and then infrequent contact with primary support group. And then so those two things were identified as well using the Prepare tool. And then homelessness, that was the last thing that was identified on there for this, test individual. So this is, just a small example from the Prepare tool, given that, it's integrated into their EHR. And they have been using this tool for many years. So they really have this process down, the workflows. But that's not to say that, somebody that, just starting, and I'll use Lourdes as an example. We have been working with Lourdes on trying to develop a process for them on, how they're going to be screening for social determinants of health and for, what's their capacity currently. So for them, they have integrated their social determinants of health into their EHR, and they are only screening for 3 things that they think that is going to have a big impact on their patient population. And those 3 things are they are screening for safety, food, and housing. So those are the 3 things. Those are the 3 questions that Lourdes is asking their patients. Do you need assistance with safety? Do you need assistance with food? Do you need assistance with housing? We are just going through the process of implementing those questions. There's gonna be we're gonna be having a training with them to create buy-in, so that the providers can start using those questions and utilizing it too in the care that they are providing for the patients, and then also identifying resources that will that they will have available to them so that they can provide to those patients. And then there's different ways depending on your size, depending on your organization, the manpower, the resources, your location, within the Greater Columbia region, or just in general where your location is. That can pose as a barrier as well, and we can see that, in the more rural counties that we work in, Columbia County, Garfield County, Stoughton, where it's more rural and those resources are harder to come by. But this example from Yakima Neighborhood Health Services is a great example of, they have it integrated. Their provider sees the determinants of health that the patient has, and then they're able to create a care plan that also involves their physical health and their social determinants of health. And then can you go to the next slide, Chelsea? So this is a success story, like I mentioned earlier. This is a story that came out of Chaz Dental Clinic out in Clarkston, and this was in collaboration with Quality Behavioral Health, which is a site that's going through practice transformation as well as Chaz. So this is the story of a 23-year-old guy, from Clarkston, and he was just having a rough time, with life. So he went in, to the clinic because he had severe dental pain. He had no health insurance. He was living in his car. He had no work, no food, and no high school diploma. So right off the bat, you guys can see, that he has social determinants of health, that are affecting his health. So no insurance, so he doesn't seek dental care. After working with the dental team there at Chaz, they identified that he had no insurance, he was living in his car, no work, no food, and no high school diploma, making him being hired a little bit harder. Once the medical assistant was done with that patient, she contacted their community health worker there at Chaz, which she dove into finding out what are the needs of this patient. So after she had the meeting with him, he was able to find out that he qualified for health insurance, and for him, he was in belief that only pregnant women or small children would be eligible for Medicaid. So that's why he had never tried. So they filled out the form for him. He was able to get insurance, and then also they did the PHQ-2 screen on that patient, and it was discovered that he needed behavioral health. So they referred him over to Quality Behavioral Health, and both of those sites, Chaz and QBH, are literally, like across the street, one block away from each other. So they were able to refer him there for behavioral health, to the DSHS for food assistance, and they refer him to a Stoughton County Housing Authority. All of this coming full circle. Now he is being seen for counseling, and he has established care with a medical provider. Joe's still living in his car, but with the help of QBH, he has enrolled in the GED program at Walla Walla Community College, where he hopes to get his GED, followed by a job that will support him getting into housing in the future with a little help from a friend. They were able to connect Joe with a few hours of work during the week, which will help provide him with a few warm hours out of the cold weather this winter. So this was this past winter. But we can see that, you know, just by asking and making sure that you have those resources available, you know, the care team and the providers can have a big impact on an individual's health just by focusing on those social determinants of health, which, you know, we learned today, and we knew, some of us knew, that, you know, those social determinants of health can have a big impact in our health throughout our life and with many different, you know, conditions. So it's not specific to one condition, but there's a you know, whole lot of health conditions that can come from social or ACEs, which then turn into, you know, those social determinants of health. Next slide, Chelsea. I believe questions. So any questions you guys have that, you know, for me and Ruben of the information that we just covered, please feel free to ask those questions or type them in the chat box.
Okay, yeah, got it. Thank you.
All right, so I'm not hearing any questions, or, you know, I'm not seeing any questions come up on the chat box. So I'm guessing
this is Cheryl.
Yeah.
I have a question, and this came up just yesterday as we were talking with staff at the Healthcare Authority who are looking at using one social determinant of health screening tool, and just wondering what the opinion would be of the providers that are on this call of, you know, your ability. I've heard about the EHR and not having all EHRs be the same, with the shared care plans not all asking the same questions or having the same template. How receptive would they be to having just one social determinant of screening tool? Is that a good or a bad idea?
Go ahead, Chris. I saw your name pop up.
I think that the difference between having one EHR and one screening tool for SDOH is a much easier question to address. Having one screening tool would be fine. It would give us a standard across the state of Washington, where trying to push for one EHR is never going to happen. You're talking about a screening instrument that's anywhere from like 11 to 20 questions, and that's something that we could easily adapt if it's a requirement from the healthcare authority. And I mean, it's similar to like what we're looking at with the native data set that we have to start reporting in the fall, that it's something that we could build into our systems and potentially be able to utilize, and it would have a standard across the entire state.
Thank you, Chris.
Hi, this is Myrna Ridenauer with Lords. My question for the standard is, how would those clinics such as Lords be able to address some of those answers if there were, because we don't have a social worker or a community health outreach, how would we be able to then help those patients that have issues that crop up and need a social worker to help them with it? Because the reason we chose the three we chose is because those are things that we know we can provide resources for. Whereas some of the other questions that are asked on them, we don't have the resources available to help patients if they have a positive answer to those questions.
But that's part of the partnership challenges, is that, you know, there are things that we don't have at Catholic Charities that Lords has that you have access to, and if we can partner with you, then you can provide them. I mean, that's part of the challenge. And part of the reality is that you're not going to be able to address all of the social determinants of health. If, you know, a client has issues with housing, you can recognize that there's a housing issue and be able to process that in context of what the behavioral health impacts of that are, and really try to find ways you can support them in finding stable housing. I mean, I think this is one of the things that SDOH points out to us, is that it's not a individual agency responsibility, but it's a responsibility across our continuum of care. And that if we can work together, then we can address some of those bigger, broader questions. If we limit ourselves to just addressing the questions that we can potentially fix, then it's really not taking into consideration the full impact of all the issues that clients are facing.
Thank you for that, Chris. I also wanted to just mention that's part of one of your milestones for collaboration, and that would also meet that agreement. So thanks, Chris.
There was also a question that we sent out, or that Brittany sent out to some providers, just asking, regarding how they're doing as far as social determinants of health. If you guys are say, hey, we have this, we have this process down, we're really good at it, or we're struggling with it, and these are the issues, as to why we're struggling. And this, there was a response to this, and I believe this was from Kendra, I believe. It says, I wouldn't say we are thriving yet. We are meeting the milestone. Challenges are, it is a cumbersome paper process, so not tied to EMR, and maybe this is okay. And there are limited local resources to offer, especially when it's housing, legal childcare, or others. So with that, what you guys just heard, do you guys want to share, how you guys are doing with screening for social determinants of health, where, hey, we have it, we're working on it, or, we're brainstorming right now ideas as to how we're gonna, be doing this. So if you guys want to share, please feel free.
This is Catherine again in Yakima Community Health of Central Washington. I just would like to say that the process for figuring out how to do this in our agency has kind of been lengthy. We ended up devising our own screening tool. We kind of built it after the Prepare tool, and then also CMS has a social determinants of health screening process. So first we built the tool, then we piloted it on paper, then we put it into the EHR, then we were getting ready to pilot it more broadly throughout the clinics, and then there was the whole COVID event, which pretty much closed our doors to a lot of patients coming in. So, I recognize the suggestion that we all use the same tool, but after putting all the work into the one that we feel like really reflects our needs in our own local community and certainly our patient population, I think that would be hard to, divest of that. But nevertheless, our intent is to screen all new patients and people every year as they update their paperwork, and then as needed along the way, like if there are interventions with care coordination, or if providers feel a need, or behavioral health, or whatever. But so far we have the process in motion, just haven't completed to gotten to where we'd really like to be.
Thank you. Does anybody else want to share?
Oh, this is Kevin Taylor. I think an issue we face too is time for our staff. Again, we don't have social workers, and so if we used a lengthy tool, 12, 20 questions, whatever, how do we accomplish that? Who has the time to review all those questions? Who would do that? MAs, nursing staff, doctors. Again, I'm not against it. I'm just saying for us that there is a time issue in terms of adding one more thing to our support staff.
Great, thank you, Dr. Taylor.
And
Martin,
there's also some. Oh, I'm sorry. There's also some comments within the chat box that people would like to share.
Yeah, I was just gonna read those. So the first comment is from Mark Lowe's from Sundown M Ranch. So he says, for SUD providers, these questions are historically asked in the assessment process, but each provider has a different way of doing it. Having a standardized screen would be useful. And then Haiti Hetlam from Skyline Health they're part of our Washington Rural Health Collaborative cohort. So she mentioned that at Skyline Health, we began screening for 3 SDOH on June 13th. We are screening for food insecurity, housing, and transportation. We have developed reporting to assess how well we are doing with screening. We will likely sit down and review the process in August, as I'm sure we will use PDSA cycles to optimize the SDOH screening form and the process as a whole. So that's what they are doing at Skyline. And then Penny Bell from Ideal Balance mentioned that they have entered it into a contract with NowPow. So trying to develop one process would be impossible for us. And NowPow, this is the company where that we are having a presentation from right after we are done with this section, which will talk about how to utilize their platform to address some of those social determinants of health, and how it can be used as a referral system. So that's coming up quick. But are there any other comments or concerns that you guys have? Hey, these are the issues that we are having, or this is how it's been working from us, and we've established this process quite a few years back, and we have refined it over those years.
Hi everybody. This is Tom Davidson with Triumph. We've had an initiative that we've been working on now for a while that has to do with trauma-informed care. And we feel like this is folded into that. And so along the lines of what Mark had mentioned, we've always, as part of our assessment, we've always tried to assess these kinds of issues. And now what we're doing differently is how can we formulate that? How can we organize it in a way that recognizes the trauma-informed nature of how we need to respond and what we need to do with our patients.
Thank you, Tom. Any other comments or questions that you guys have for either myself, Ruben, Sam, anybody of us, regarding the information that we just presented to you guys?
Martine, this is Diane. I was just going to make a comment that, like Chris was saying, when addressing the social determinants of health, it is key to have, partners with social service agencies and to address these social determinants of health, and have ways that as an organization you can reach out to other organizations to help address these, that they don't have to be addressed all internally. That's why we have so many different organizations, and the key is building this network between all of you to be able to help address these for your patient populations.
Thank you, Diane.
Yeah, thank you. If there are no other questions or comments, then we can take a break and then be back here at 11.
Welcome back, everyone. At this point in time, we'll turn it over to Scott Woozencraft and Brittany Lee from NowPow for their presentation.
Hello, everyone. I'm Brittany Lee from NowPow. I'm going to share my screen with you guys now, if that's okay.
Good morning. This is Michael Cunningham of Ideal Balance. I'm here to introduce Brittany Lee and Scott Woozencraft from NowPow to talk about their great platform for providing clients with community resources. So, Brittany, do you want to start us off here?
Sure. Well, thank you all for having us. Today, we're going to do a little bit of welcome and introductions. Have Mike tell you a little bit about what Ideal Balance is up to. Then I'm going to do a quick overview and demo for you guys of NowPow. And then we can talk more about the referral receiving partnership. And then, of course, we'll leave time for any questions and answers and next steps.
Okay, so again, my name is Mike Cunningham. I'm the offsite director for Ideal Balance. And Ideal Balance provides behavioral health services in 31 Ideal Option Suboxone clinics in Washington State. So we've been associated with NowPow since late last year, and our clinical team so far this year has screened over 300 clients in Yakima, Benton, and Franklin County. We screen all the clients for the social determinants of health at assessment at intake, and we match those needs with the community resources. We're 300 clients this year in the 3 counties here, and have actually shared over 3,000 community resources. And a lot of those resources, of course, are you guys. So anyway, Brittany, do you want to start that little overview?
Sure. Well, Mike just gave you an overview of Ideal Balance and what's happening. And just to introduce myself, my name is Brittany Lee. I'm a Senior Community Engagement Manager with NowPow. We also have Scott on the line if you want to introduce yourself, Scott.
I'm Scott Woozencraft, Senior Account Manager, supporting the Ideal Balance team. Grateful to be here. And grateful for the work that Ideal Balance has been doing. It really piggybacks Diane right before the break let out, sharing resources and relying on one another for our service expertise and kind of the wraparound services we can provide clients. Speaks really to NowPow's mission and also the great work Ideal Balance has been doing in getting these referrals shared. So we're excited to take a deeper dive there with you today and learn about how we might get a little more networked into one another here.
Great. Okay. I'm going to go into a little bit about NowPow now. So NowPow is actually a play on knowledge is power. And here at NowPow, we focus on whole person care for whole communities. So we do that by connecting people to the right resources in an easy and efficient way while using our community referral system. And so how NowPow works is that across every tool on our platform, you can identify, match, and share referrals. Once you identify that your client has a need, which you can do using screenings or risk factors, you can match to services that are needed and then generate a personalized list of referrals that you can either print, text, or email to your client. And then when you become a tracked referral partner, you can track the referrals that you coordinate with Ideal Balance, for example, to close the loop on care. And then you're also able to use bi-directional communications and reminders throughout that process. So you can send messages to the person that sent you the referral initially, and then you can also send appointment reminders to your patients as well using the technology. And then we also have the analyze function, which is where you can also use data to analyze the referrals that are being sent out and received. So when you're a referral partner of Ideal Balance, their users will identify patients that could benefit from referrals to your organizations. They will then send a track referral to your organization where you can outreach the patient and link them to programs and services. And then throughout the entire process, you can update the status of the referral so that Ideal Balance is aware of the progress and you guys can communicate with each other to make sure you're able to close the loop on that referral. And then NowPal's tools work to keep Ideal Balance clients in your organization all connected, and it's catered to the referral sender, the referral receivers, and to the people you serve as well. And then the technology also helps to identify matched resources, support people, track referral progress and outcomes, and then it also helps to ease the workload of care professionals by all of the information being there so you don't have to search for it. And then it also helps to build better resource networks. And so I gave you a little bit of information here. I'm going to do a quick demo for you guys. I need to stop sharing for a moment so that I can go to the other screen. Just give me one moment. And if you have any questions at any time, please feel free to stop me. Give me one moment here. Okay. Actually, here we go. Okay. So is everyone able to see my screen here? Just want to make sure. Yes. Okay. So when you're signing on to the platform, you'll have your username and your login information. And I'm going to sign into one of our demo accounts so I can show you what it will look like on your end. So when you sign in here, you'll have your top tabs here, which are your referrals, your ERX, or electronic prescription as we call it, which is the resources and referral that you would send to your client, and then your services, and then dashboard, which is where you would have all of your information on how many referrals you received and things of that nature. So on your main screen for your referrals, you would have all of your patients here. And let's say, for example, you received a referral for Alex Adams for a food pantry. Your person on your end would be able to go in, see all of Alex's information, see who it was made by, who the referral source was, be able to send a message. And in this case, Scott sent me this referral. And then you would also be able to leave a referral note. So this one says they prefer services here in Spanish. Need is urgent. Please call ASAP and let Scott know if there's any problems. So once you receive this referral, you would be able to go in and update the status. So you can say whether or not you're able to accept this referral, the contact status as to whether or not you were able to contact the patient. So let's say you were able to get in touch with Alex. And then here, you get to add an appointment if you guys are taking appointments. And then you can also say whether or not your client denied the service or was ineligible for the service. If they took the service, you can say yes. You can give the outcome that it was successful. And then you could also leave a note here. And once it's all completed, you'll be able to close that referral. And now it's no longer on your list. There's also another view here, task view, where you can do all of the same things. And if you notice here, this one has a message. You get this orange banner here on the side, and you'd be able to read the message that's going back and forth. So in this case, Alyssa got a message saying that she wasn't able to contact Frida, and they were able to go back and forth here and give the updated information about Frida. And then also, once this is all accepted and contacted, if I added an appointment here, let's say that the appointment was tomorrow at 9 p.m., I could save that as well. And now that I've saved it, the appointment is now here, and we're able to find that it's here, and we have upcoming appointments. So it's moved to a different tab here. We could also send a reminder to the patient to remind them of their appointment. You can change the language of it. So let's say, for example, they spoke Spanish. It would now translate all of the information here into Spanish, and we could either text it to the patient or we could email it. Okay, so that's pretty much how the referrals tab works. And then here, when you are in the electronic prescription tab, this is where you are able to set up an electronic prescription for the patient. You can put in the patient zip code, and these two will populate. You'll have service categories and conditions. Under service categories, these are all of our different categories where you can find different services. So for example, let's say that we know that this patient has food insecurity. You can go under food and nutrition and you could look for a food pantry, for example. And then let's also say that they're having some mental health issues that they need help with. You can also check individual counseling, for example. You could come to the bottom and click next. And then we'll also have an array of filters that come up. So for example, if you know that they speak Spanish, you could change this. If you're looking for something, that only caters to females or males, you can do that as well. We also have updated our COVID-19 status. We have a team of people that are calling on a regular basis to make sure that things are still running during COVID, because we know that some things are now become telehealth, or they're just curbside pickup, or they're no longer in service. So you can do it based on that as well. You can also do it based on age. So let's say they want something that for people 25 and older can go to, and you can change the distance as well. So let's say this person has a car, so 10 miles isn't that bad for them. And then when you click on that, you would get a list of the different services that are available in that area. It's going to give you the top 2 closest ones. So here are the 2 food pantries that are available. You can also go in and view alternatives. So if you didn't want to use that food pantry, you think this one is a better fit for your client, you could check that one instead and uncheck this one and update it, and it would come here. Now it's come there, and as you see, here's the COVID-19 status that I spoke about earlier, that it's now pickup. We also came down here to the mental health section. These are the 2 mental health places that are closest that the technology thinks would be a good fit. You could also leave a note here for the patient or client, letting them know, like, hey, see Jessica when you get there. And you can add that comment. And then once you've decided that these are the resources that you want to give to the client, you can save it. And then you can also, once again, change the language to any of these languages. You can download to print if they're right there in front of you, or you could nudge, which is what we call texting or emailing, and do the same thing. You could text it, email it, change the language as well for the patient. You can write anything else in here that you want to write in, and send that off to the patient. Another way that you could complete this is by doing it based on conditions. Oops, let me put the correct zip code in. Okay. So if you know that your patient has any of these conditions that are listed here, you can go and find them. So let's say, for example, they have diabetes, and then once again, they also have food insecurity. You could click next. Once again, do the same filters that would come up, and you would get that list again of different things. So now it's suggesting nutrition counseling because they're diabetic, and we have a list there, SNAP registration because they have food insecurity, soup kitchens, and then also a chronic disease self-management program. And with this list, you can once again change the language. You can nudge it, which is email or print, or you can download to print for the patient. While I'm in here, does anyone have any questions about that? And I'm sorry, I can't, while I'm in this zone, I can't see if anything's typed. So.
I've got you covered there, Brittany.
Sorry, what did you say, Scott?
I've got you covered on the typing front.
Oh, okay, thank you. Okay, so that is the demo there. And I'm going to go back in to where we were. And then I'm going to go back to our, yes.
Brittany, can you hear me?
Yes, I can.
Okay, my name is Wes. I'm with the ACH. I have a couple questions for you. First of all, in that list of all those use cases or examples, such as food insecurity, diabetes, etc., is that something that organizations can edit if they want to create a specific use case? Is that possible?
I can jump in here. As like a ComRx partner, we generally don't do custom condition algorithms, but I think is what you're driving at, that conditions tab there. But that is something within the broader NowPow use case. If somebody comes on board as a customer, there is the option to do custom condition algorithms. So you could set up, let's say, I know diabetes is on the list, but let's say diabetes wasn't on the list and that was important for your organization. You could create a diabetes button, map that to specific service types, resources that would support that need, and take that live for your organization. So what you're getting, the account you just saw up on the screen for the demo was what you would get if you signed up to receive tracked referrals from Ideal Balance. It's a free account, no charge at all to it. But with that, we don't do custom condition algorithms. You get the standard set of conditions that are listed in NowPow. Comprehensive, okay, but not tailored.
I got you. So my second question is relating to 42 CFR. So obviously, or likely, anybody coming out of, say, Ideal Balance will have some form of substance use disorder. So I'm just wondering how compliant and how rigorous is the consent management process relative to 42 CFR?
Yeah, and Mike, feel free to jump in with me on this one too, but there's a document management function in NowPow. So anytime anybody is sending a track referral from Ideal Balance, they will be consented. Each and every track referral, that track referral will be saved to that. The document will be saved to that track referral as it's sent over. Something that is certainly on our mind and a great question here.
So I'm not quite sure if that answered the question. Is it have you gone through some sort of compliance process to make sure that it is compliant with 42 CFR?
The consent is something we've worked on as an organization with the Ideal Balance team. As far as the specific process that went through and kind of the stress tests involved there, can't speak to those at the moment, but I can dig into that for you. We would, before any tracked referrals come live, 42 CFR is certainly something we're familiar with and ensure we're in alignment with before anything goes out the door.
Yeah, currently, I'll jump in here, Scott. I'm sorry, I was on.
No worries.
We won't send any client information to any agency without a QSOA in place. And so currently, the majority of our referrals are given directly to the client for them to follow up. And then, of course, we follow up in one-on-ones or ISP reviews, things like that. But my goal is to get some QSOAs in place with some community partners so that we can actually track the referrals back and forth. Does that answer your question?
Sort of. Thank you.
Yeah, and all the clients do, whenever we give them a list of referrals, we also have them sign, just as a precaution, they sign releases to all those organizations as well.
So I'll just speak a little bit about another care coordination system that we set up in another region of the ACH. The consultant that built that process worked with the state of Washington and their chief compliance officer, who's a lawyer. And their job is to obviously enforce standards around 42 CFR. So they made sure that that consent management process for that electronic referral care coordination process was compliant. And I'll stop there.
Okay. All right. Any more questions?
I do have a question. This is Carol from Greater Columbia. We hear a lot about referrals and referral networks and care coordination. I mean, this is a huge subject across the state with all of the ACHs, and the need to have patient navigators or care coordinators kind of like hold the hand of some individuals that just have difficulty coordinating their own care. To me, this sounds more like, you know, electronic or digital systems, not necessarily having a community health worker walk with that person to the food bank. How often do the patients, you know, follow up on these referrals? What has been the success rate or the experience of Ideal Balance and getting the patients the social determinants of health care coordination that they need? And maybe Penny can answer that question. I don't know.
I can jump in from, and Penny, jump in front of me, please, if you've got more to add. I think this is the opportunity to close the loop on the referral. Right now, the resources that are being shared are being given to the participant in Ideal Balance programming. But then from there, you know, aside from like follow-ups that go out in future appointments or nudges, there's some communication functionality in NowPow that can help a provider text or email the participant. There really isn't the built-in functionality where the other provider can say, yes, I saw this person at our food pantry. When an organization steps on board to have their food pantry serve as a track referral partner, though, that's when you can really start to see that robust data that says, yes, this person who identified with a food need at Ideal Balance, in fact, got that food need met, you know, at this other provider in the community. So we're like a half step shy, I feel like, of really being able to close the door on that data, at least within NowPow.
We review the screening process, you know, with the clients at just about every session, and the clients are following up with the referrals and asking, in a lot of cases, asking for more because they realize how much information we actually have in our system now for referrals. So I think it's more than usual, but it's really up to the client to let us know if they're following through.
Thank you.
Great. Okay, there's no more questions. I'll move on a little bit and then we can come back to questions at the end if you have any more. Just got one more thing here. So after you've seen the demo, probably like why partner with Ideal Balance and NowPow. So these are a few of the reasons why. So if you partner with Ideal Balance and NowPow, you will receive free access to NowPow's resource directory, as Scott mentioned. And then with the partnership, it'll actually help you gain data, access to service, and enhance collaboration across the network, while also reducing care gaps for your mutually shared clients. And then it will also help you gain access into how Ideal Balance's clients are utilizing your programs and services. And then it will also help to increase your referral volume and reduce your no-show rates due to being able to track the referrals that you receive. And then once again, that's kind of the end for my part of the presentation. Are there any more questions? Okay. If not, so
They do. I'm sorry. I just have a quick. I see a question in the chat box that says, "What is the cost of NowPow?"
So as a referral partner, it's free to you.
And that's our more basic platform, but yeah, as a referral partner, you get access to the resource directory and quick and efficient access to share resources. So that is certainly a big benefit. There are step-up platforms on top of that. For example, Ideal Option, having the ability to send referrals is actually a part of our PowerX licensing package. And that varies in price depending on the number of licenses and how you're set up. But if there are questions there and specific pricing is requested or more information on any of our kind of step up platforms is desired, I can certainly field those questions. And I'll share my email right now in the chat box.
Great. So as next steps, there'll be a follow-up email coming to confirm any interest, and if needed, any additional contacts with your organization. And here are our emails and contact information if anybody needs them. And Scott also is going to put his in the chat box as he stated. And I just want to say thank you for allowing us to come and do this demo and presentation for you.
Is there any more questions for the whole presentations for today?
Sam, this is Carol. I just wanted to thank you and your team for the great presentations on the shared care planning and social determinants of health, and helping answer some of these hard questions that we get at the state level. It's hard to know how to answer these questions without having provider feedback. So we really appreciate the providers who have participated and offered up some opinions about those important topics. So thank you.
Oh, you're very welcome. Thank you, Carol. Thanks for providers and for all the attendees for participating in these learning collaboratives. Without your voice, we really don't know how to answer those questions that's at stake, as Carol said. So we really want to be an advocate and be able to lead the Greater Columbia to have their voice heard. So I appreciate that, Carol.
This is Diane. I just wanted to make a comment too. One thing with the NowPow presentation that they have a full team that can answer any questions, but it is really important for the SUD and behavioral health providers, and a lot of it is because the EMRs are really limited, so this really would help with that. And so I hope that that you guys will be able to reach out to NowPow for any other additional questions that you will have.
Yeah, the process to coming on board as a track referral partner is really pretty straightforward. And NowPow, and especially Brittany's a rock star and works with these referral partners to make sure that they're set up to receive referrals from Ideal Balance and support those clients with wraparound services, but also there to support your use of the platform and make sure you're getting your own work out of it and your own ability to share great resources out of it.
Great, thank you. I don't see any more questions in the chat box. Once again, I appreciate all the attendees, and truly our providers are our rock stars out there, and we appreciate all the participation and really being a great partner for the Greater Columbia region. At this time, I'll give you 2 minutes back of your morning and appreciate it again. Thank you. Goodbye,
This
everyone.
is Diane. I just want to say one more thing. So on August 6th, we're going to be having Allison Masari. She's going to be presenting. We're going to be doing it through GoToMeeting, and it's going to be a really great hour and a half that we have, and I really hope that everybody can attend. And so it'll be on August 6th at 2 o'clock. So I hope to see you guys then.
Thank you, Diane.